Hi, my name is Dr. Jenn Wilhelm, and I am excited to be speaking with you today about my research on developing novel therapeutics to treat peripheral nerve injury. And I'm very excited to share the research that my students and I have been doing over the last several years. So first of all, I want to start off with a little overview of neuroscience. So a lot of people, when they think neuroscience, they think of the brain, and it's an important part of the nervous system, but it's not the only thing. So the central nervous system consists of the brain and the spinal cord, and then we also have this rich peripheral nervous system of all the nerves that come off the brain and the spinal cord that gives the ability to walk and to talk and to feel things. So it's this really rich network of nerves that come off to allow us to have all the behaviors that we have. Unlike the brain and the spinal cord, the peripheral nervous system is not covered by bone. So you can see over here, we have the spine with the spinal cord on the inside. Inside the spinal cord, there are motor neurons. These are the neurons whose axons go out to form the nerves that go out to the muscles and allow us to move our muscles. We also have processes coming in that bring in sensory information from our skin and from our muscles for pressure and pain and touch and vibration and proprioception, so understanding where our muscles are in space. And those signals come in, and they come in through the nerve, and then they enter into this bony area and go into the dorsal root ganglion before going into the spinal cord for processing. So the spinal cord is very well protected, the brain's very well protected, but unfortunately the peripheral nervous system, a lot of these nerves are not well protected by bones. And unfortunately that means that they're open for trauma. And about 100,000 Americans end up experiencing some type of traumatic peripheral nerve injury every year. This is a very large number of people. And it ends up being that most of these people, about 90% of them, end up with a loss of function that's permanent. So they end up with something, they don't end up with the nervous system dysfunctioning the same way that it did before. And in fact, 100,000 people, while that sounds like a lot, is probably a low estimate of the people who actually sustain nerve injuries any given year. In fact, most of the people who are here today probably have sustained some type of peripheral nerve injury in their own lives. Probably more of a moderate one. If you've ever gotten a bad cut, congratulations, you probably have damaged your peripheral nerve system. Fortunately, unlike the brain and the spinal cord, the peripheral nervous system can regenerate. And for very small cuts, you're likely to have the skin heal, the nerves to heal, and to not be left with any functional deficits. Unfortunately, a few years ago, I cut off the tip of my finger, and it was able to get sewn back together. The nerve was able to regenerate, but I was left with some deficits. The tip of my finger kind of feels like when it's really cold outside and that you come inside and that kind of numb burning feeling. That's what my finger feels like all the time, which is not normal and definitely not like what it was before I had my injury. So I'm part of that 100,000 people. The part of the peripheral nervous system that I study is the sciatic nerve. So this nerve has motor neurons here in the lumbar region, kind of mid-back region of your spinal cord. They have axons that come down, the motor axons that come down. They exit the spine and they go down along through your pelvis, along through your thigh, through past your knee, through your calf, down to your foot. And they help with all the muscle contractions in your major leg muscles, including dorsiflexion, so being able to flex your foot. We also, in the sciatic nerve, have sensory information coming through there. So from the skin, from the muscles, and that information is going to travel up through the sciatic nerve, up into those dorsal root ganglions to bring sensation to that area. So the sciatic nerve is mixed motor and sensory. It is one of the largest nerves in the body, and it is prone to damage. People end up damaging it through stretch injuries, through irritation injuries, and unfortunately through traumatic transection injuries like I study in the lab. So for people who end up with transection injuries or really severe traumatic injuries, really the only method that has been adopted or accepted for treatment is surgery. So people who have traumatic injuries end up going to a surgeon, and the surgeon's job is to basically put that nerve back together. So if you're squeamish, look away for just a moment, but I did want to show you what a nerve looks like. So here is a nerve bundle. This fatty stuff that we're seeing is the nerve. This glistening white stuff is the nerve. And inside are all those bundles of axons from the motor neurons and from the sensory neurons. Here you can see where the cut happened. The surgeon in this case was able to suture it back together, and then the nerve itself is able to continue on this side, but we don't have any of those axons. So those axons have now been cut. So we're only having the original axons going to about here. In this case, like I said, the surgeon was able to stitch this back together. That doesn't always happen. In a lot of cases, people have more tearing, they have more damage, the nerve pulls apart, it's kind of like a bungee cord, and it has a lot of flexibility, and people are left with large gaps. And in this case, the surgeon might use cadaver nerve or nerve harvested from another location within the same person's body to be able to fill the gap. So for most of the surgeries that we do, we're interested in these really clean transection injuries that the surgeon's able to cut and to suture back together. Even in this case, what people who have these cleaner injuries that are able to have them sutured back are left with a lot of deficits, and this is because, like I kind of alluded to a moment ago, our motor neuron, the neuron that has axons that go down to the target musculature, are damaged, and they have some type of changes that occur. So here on this left-hand panel, we have our motor neuron with its axon that goes down to the target muscle, and we see these green cells. They're not green of the body, but they're imaged green right now. These are Schwann cells, and these are the myelinating cells, the peripheral nervous system. And when an injury happens, like right here, what you're going to have happen is you're going to have a cut to that axon, and anything distal to the cut, so anything no longer attached to the cell body, is going to die. So those axons are going to start to bleb. The Schwann cells that used to myelinate don't have anything to myelinate anymore, so they come off and they become reactive. They start releasing factors to help this area. We have the macrophages coming in and infiltrating the area. We have immune response that occurs, and we basically have denervation of this target musculature down here. Anything still attached to the cell body can remain alive, and you can actually see that we have a little bit of a growth cone that can start to form fairly quickly at the end of this cut axon. With all these growth factors that are being released from neighboring cells, as well as from these Schwann cells that are now reactive, you can start getting regeneration. So you can start getting growth of this axon from the cell body that is still there. And it's going to grow very slowly back towards the target musculature. So unlike the brain and the spinal cord, the peripheral nerves can regenerate. Unfortunately, it's a really slow process. So this takes a long time, depending on where the target musculature is and how far away the injury was. So for my finger, I had the tip of my finger. We're very far away from the cell body, but we're very close to the target musculature. So it only took a few weeks for that to recover. If you had been up here closer to the brachial plexus, then that's a long way from the target musculature down in my hand. So that could take potentially years for that sort of regeneration to occur. And unfortunately, these growth factors that are coming out of these reactive Schwann cells probably only are released for a few months. So this means that we need to come up with some type of therapeutic to encourage axons to regenerate and to regenerate properly. So even if regeneration happens, and sometimes it does, where the axon is able to get all the way back down to the target musculature, it doesn't always happen accurately. So here is a schematic where you can see the inside part of the nerve. We've kind of taken off the outside bundles, and you can see the axons with the myelinating Schwann cells, and these axons are going towards some type of target skeletal musculature. So in this case, we're looking at motor neuron axons, just part of our sciatic nerve, and an injury has occurred. So it's occurred right here. You can see Wallerian degeneration has started to occur. We're getting the blebbing of the axons as they're dying away, and you're getting the astrocytes turning into reactive astrocytes, and the denervation or loss of innervation for the target musculature. And then as regeneration starts to happen, as we talked about before, we're going to start having sprouting. So these axons are going to start sprouting, and they're going to try to find the tubes that they were once in. So these act like tunnels to be able to take it to its target musculature. But you notice if you look at this little guy right here in the middle, that before his axons went down into the middle of the next tube, and this time it's found its way into the top tube. So this is called misdirection, and misdirection occurs, and it's really important that because it ends up having problems with functional recovery. this tube is going to potentially go to a different muscle than this tube goes. And in fact, in a mixed sensory and motor nerve, like we study, you could have a situation where a motor neuron could enter into something that may have led to a sensory tube. Or you might have something that was sensory that's now going towards target musculature. So this type of misdirection ends up being very functional, has a high functional consequence. You could end up in a situation where you have one motor neuron that's supposed to go to one muscle, now going to the wrong muscle, and maybe even going to an opposing muscle. So normally our muscles have contractions and relaxations. So you might end up in a situation where a muscle is now getting innervated by a motor neuron that's trying to form contraction when really the muscle should be relaxing. So you can get co-contraction. That causes stiff muscles. It causes lack of coordination. This is a really big problem. So while regeneration is great, it can happen, it's very, very slow. It can go in the wrong place. And we really need to come up with some type of pharmaceutical or some type of therapy to help the problem, to help people to get regeneration to occur after their peripheral nerve injury. And if it's not bad enough, regeneration is not the only thing we need to have happen. While regenerating, my focus and our focus in research has been on the innervation of the target muscles, there have been changes that occur in the central nervous system too after injury to the peripheral nervous system. So as I mentioned earlier, the injuries that we're talking about are all in the peripheral nervous system. However, the peripheral nerves are just bundles of axons from either the sensory neurons in the DRG or from motor neurons that live in the spinal cord. So whenever we have injury to this peripheral nervous system, to this axon bundle, then you're going to get changes that occur in the central nervous system too. And one of those changes is a reorganization of synapses. So here's a schematic over here where it shows a motor neuron that's coming off of a muscle. It's here's the neuron itself. Here's this axon going to the muscle, and then we have a sensory neuron over here that's going to get proprioceptive information, going to bring it into the dorsal ganglion and then into the spinal cord. And notice that that sensory neuron makes a connection onto the motor neuron. This is an important connection. It gives us all types of functional behaviors, such as reflexive actions. So I can, for instance, if you reach out and you touch something that's hot, you can get that sensory information coming in. It sends a message to your muscle, or to your motor neurons, and then sends a message to your muscle to actually get your hand to come back before your brain even processes it. So this is one of those motor sensory relays. When you damage those axons in the sensory motor nerve in one of the sciatic nerve, you're cutting both of these. You're cutting the sensory and the motor processes. And when you do that, we see a reorganization or withdrawal of the synaptic connections from the sensory neuron onto the motor neuron. So normally the motor neuron gets lots and lots of messages from sensory neurons and from other things called interneurons. And these are trying to tell that motor neuron what to do, how to contract, when to have a muscle movement, and not to have a muscle movement. And after it's been injured, after the motor neuron, the sensory neurons have been injured, almost all of those synaptic connections come off. Well, this is problematic because now you have a system where even if we get these motor neurons and sensory neurons to send out the processes and regain that target musculature or the target sensory organs, if we don't have the correct messages going together, the sensory neurons and the motor neurons, then we can't have organized functional behaviors. So this is going to be a big problem. So you have lots of different things happening after peripheral nerve injury. We have to regenerate to the right place, and we have to deal with the synaptic reorganization in the central nervous system. And right now, the only way to deal with this has been for people to go to surgeons. And a lot of patients who suffer peripheral nerve injuries, specifically in the sciatic nerve, are left with a lot of functional deficits. Now, as I mentioned earlier, only about 90% of the people are left with some type of major functional deficit. And this could include things like foot drop, so not being able to pick up your foot to clear the floor, so your toes kind of drag along before you can actually take another step. You have waddling gait, swinging out gait. You might have a steppage gait, or just some type of instability in your motor plan and through your hips. You might have weakness. So these are all really big problems. And so typically what a surgeon does is after the surgeon has repaired the nerve, they will send people to a physical therapist Often this is because those muscles that were the targets of the injured nerves will start to actually change. They'll start to waste away, they'll get smaller. So a lot of times originally the surgeons sent people to physical therapists to get their muscles stronger. But then the question became, what is this physical therapy doing for the neurons? Or is it affecting the neurons in any way? So I started working with some physical therapists and some colleagues at Emory University, and they started asking the question, we started asking the question, what kinds of physical therapy do people do when they have these types of injuries? And one of the main therapies that kind of came out of that was treadmill exercise. So treadmill training as a form of exercise is a therapeutic tool that a physical therapist often use. So working together with these colleagues at Emory, we set up an experiment to test to see what effects physical therapy and what effects treadmill exercise would have on the nervous system. So we use a mouse model because realistically, very few humans are going to be willing for me to do traumatic nerve injuries to them. So we do use mice. We use males and female mice. And these are not pictures from my lab. These are ones I found off the internet that are representative of what we do. So we anesthetize the animals, we expose their nerve. This is the common fibular nerve. It's a branch of the sciatic nerve. We expose it. We then use a pair of surgical scissors to cut the nerve, and then we repair it. So you can see here's the cut nerve, and then this one, it's hard to see white on white, but the nerve is actually repaired. We repair it with a fibrin glue. We literally just glue it back together, sew the animal up, and then within 2 to 3 days after the surgery, we started treating them with exercise. So talking to the physical therapist, we said, well, what kind of exercise paradigms do people use? So this was a study done by Mary Sabatier and Art English at Emory University, and they discovered that people typically used one of two paradigms, either a continuous paradigm in which people or animals, in this case we did animals, ran on a treadmill for 10 meters per minute for 60 minutes a day for 5 days a week. So 10 meters a minute, just to give you some perspective, is really, really slow for a mouse. Their top speed for this type of mouse, for a CP27 Black 6 mouse, is about 35 meters per minute. So going 10 meters per minute is very, very, very slow. So they can usually do it. They're usually very good runners by the 3rd day after their surgery. The alternative exercise regimen or paradigm that we've used is a much faster 20 meters per minute, so double the speed. And this is done for 2 minutes duration and then a 5-minute rest, and there are 4 repetitions. So 2 minutes at high speed, then a rest, 2 minutes at high speed, then a rest, 2 minutes at high speed, then a rest, and 2 minutes at high speed, and then you're done. So we use these 2 alternatives and ask the question, does this type of exercise change the elongation of axons, motor axons after injury? So to do this, this animal is a really special animal. It was bred to express yellow fluorescent protein in a subset of its axons. So that's why we can see these bright kind of greenish yellow axons. They're expressing yellow fluorescent protein. And here's a schematic of the sciatic nerve with the common fibular branch over here. So these axons will be coming down here. And then we introduced that nerve cut that I mentioned earlier. And instead of just putting the nerves right back together, in this case, we took a piece of nerve from another animal that did not have those yellow fluorescent proteins. It just had a normal expression of normal proteins, so non-fluorescent proteins. So it provided a blank background, and we grafted that in, secured it with fibrin glue, and then we were able to exercise animals for 2 weeks and then harvest the tissue. And in this case, what we can see here is you can see the axons proximal to the cut. So these are going to be the parts that are going to be attached to that motor neuron cell body, so the parts that stay alive. And then this white line represents our cut. And then anything on this side is going to be distal to that. So all the green axons you can see on this side are ones that grew after the cut. And you can see that in this control, untreated, unexercised animal, that the axons grew to about 1,000 microns, which is not so bad for sitting around for 2 weeks in a cage. However, the animals that received exercise grew to about 2,500 microns long. So this is a big difference. So we were really excited to see exercise does enhance this by quite a bit. So this was very exciting. We then had some students that we brought into the lab and had to try to help us replicate some of this data. And they couldn't. They kept coming back and saying, no, it doesn't work. It doesn't work. And we knew that something was up. And we started talking to them more about what their research, what they were doing. And we discovered that one of the students happened to always pick male animals. The other student happened to always pick female animals. And due to some variations in their schedule, one of them had always been picking the interval schedule, and one of them had always been picking the continuous. And through the serendipity, they ended up discovering that, lo and behold, we had a sex difference in the way that exercise works in regeneration and enhancing regeneration. So this work was done by Kylene Wood and Kevin Liu. When I was working with Art English as a collaborator and also manning Sabatier. And what we discovered is that in untreated, unexercised animals, that for male, which is in blue, and female, which is in this pink color, that they had normal axon regeneration of about 1,000 microns. Same thing. However, when you treated the males with that continuous, slow 60 minutes per day, 5 days a week for 2-week exercise, you got this massive increase in the length of the axons. It went up to 2,700 microns, but the females did not. It didn't enhance it at all. It was just like the animals had been sitting around, but they had been exercising a lot. So that was really interesting. So we said, well, what's going to go on with the interval training? So we did the same thing. And in this case, we found out for interval training, you get a huge increase for the females. They go up to about 2,200 microns, but the males don't have any enhancement. And this was amazing. It was the very first description of some type of sex difference in the way that exercise worked, particularly in these motor neurons, which are not thought to be sexually dimorphic. So this was a really big deal. And it led to a lot of questions about how is this happening? Why is this happening? What's going on? And I promise I'll tell you, but I want to take a slight turn before we get into the how and the why of what went on with this sex difference. And I want to go back, and I want to go back to this figure that I showed you just a little while ago, that showed you whenever we have an injury, and the injury occurs here, we do have regeneration occur. But you might notice that before you had a one-to-one relationship between this axon and its target. So you had one axon going through one tube, and that was it. However, when you start having regeneration happen, you can see that this axon right here, this motor neuron, it actually has one axon that goes here, and then it had a branch. It branched off. It sprouted. And you have another branch going over here, and you can see these little branches going in these directions, and they're going to keep continuing. So one of the challenges about doing some of this research when we're looking at elongation as a metric for regeneration is that we could be looking at regeneration, which is going to end up reinnervating our target musculature or going to our sensory organs. But we also could be looking at just a whole bunch of sprouts coming off of a few motor neuron axons. And it's really not going to end up being a functionally significant change. So the question became, how can we look to see if we're going to have some functional differences in the number, if we're going to be able to tell the difference in the number of motor and sensory neurons. This is also important because before we could just look at axon elongation, but we couldn't tell the difference between motor and sensory. And this is a mixed nerve. And it's going to be important for us to get regeneration of both. Because even if you get the axons from the motor neurons to reach the target musculature and you get muscle contraction, that's great. But if you can't feel if your foot hits the floor, that's a problem. So you need to have regeneration of both sensory and the motor components. So in our lab here at the College of Charleston, we did some experiments where we went in with our male and our female mice, and we anesthetized them. We cut the nerve, we then sewed them, we glued it back together, we sewed them up, we gave them the exercise either in the continuous paradigm or in the interval paradigm. And then after 2 weeks of exercise training, we came back in and we did a second surgery in which we went 1,500 microns past the first site. And we picked 1,500 microns because the average length of those axons for the uncontrolled or the untreated, unexercised animals was about 1,000 microns. So we went past where normal animals would have some regeneration, so we could pick up anything that was greater than just untreated. And we applied a retrograde label. And this is a dextranamine conjugated dye that is able to get picked up by the molecular motors in the axon and able to be retrogradely taken back up to the cell bodies, both the motor neuron cell bodies and the sensory cell bodies in the dorsal root ganglion. And then 3 days after that surgery, we harvest the tissue, we slice it, and we're able to count the number of labeled motor neurons and count the number of labeled sensory neurons. So what these students found, so this was done by Melina Costa, Jamie Harrell, and Trisha Copley, and what they found is that exercise had a very big increase or very big enhancement effect on the number of motor neurons that participated in regeneration. So in this figure, we have the fold change in the number of labeled motor neurons normalized to the unexercised untreated. So that would be this dashed line here, 1, that's 100% was the indication for the untreated. So anything above that is going to be enhancement. Anything below that is going to be worse than just sitting around doing nothing. And as you can see, for both males and for females, we have an enhancement. We have a larger number of motor neurons participating in regeneration for these exercised animals. This was great news. So then we asked the question, well, is this the sex-dependent states for the paradigms like we saw before? So it doesn't matter if animals got continuous training versus interval training. So Alison Bruce, who worked in the lab for several years, she did some experiments where she counted the number of labeled motor neurons compared to the untreated animals, again, also here at this dashed line. And she discovered that males with continuous training had a massive increase in the number of motor neurons that were participating in regeneration, but females did not. And then alternatively, we had an increase in the number of motor neurons participating in regeneration for females, but actually not a statistically significant effect of the interval training for males. And I do think that this is probably not significant. So once again, we found a sex difference. And this is incredible because these are not sexually dimorphic cells, but they are responding differently to the exercise. So this was pretty interesting. So we found this effect on motor neuron participation for exercise. So exercise increased participation and in a sex-dependent way. So then we asked the question, well, what about the sensory neurons? Are the sensory neurons actually being affected by this treadmill exercise as well? So again, Alison Bruce did this research, and she found, again, the fold changes in the number of sensory neurons that are here on the y-axis. The x-axis is male and female who have been treated with exercise, and the dotted line represents the untreated animals. So we found this increase in the number of sensory neurons participating in regeneration for both male and female. So this again was very exciting, probably even more exciting than our motor neuron information, because this was the very first demonstration that sensory neurons even responded to exercise. So not only could we start looking at the differences between males and females, but this was the first time that anyone has shown that sensory neurons responded to exercise. It's been known for quite a long time that motor neurons had. So this was a very exciting finding that Alison made. So she then asked the question, well, is there a difference in the paradigms? Are we going to see any sex differences? And for sensory neurons, we were very surprised that it didn't matter. So males that were treated with the continuous and females that were treated with continuous exercise paradigms had an increase in the number of sensory neurons participating in regeneration compared to that dotted line, which is our control. And males and females treated with interval exercise had more sensory neurons participating in regeneration compared to control. So for this one, it didn't matter. And I thought that was fascinating and encouraging, because then patients could potentially be treated with the continuous exercise for males, the interval exercise for females, and we could potentially end up in a situation where that would help with the motor neuron regeneration and with sensory regeneration, and at least not be a deficit. It's not going to cause a problem. So this was really encouraging. So even though we didn't see sex differences, that exercise works, and it doesn't really matter which one you give them for the sensory neurons. So we then started to think about what's going to happen to exercise with these synaptic connections. So we've looked at axon elongation, we've looked at motor neuron participation, sensory neuron participation, and now what's going to happen to the synaptic reorganization in the central nervous system I talked about. So we talked about earlier that after the peripheral nerves are damaged, that you get this reduction, you get this withdrawal of the synaptic connections onto injured motor neurons. And we can see that over here. So it's this change in synaptic coverage This is an intact animal. Here will be the 0 line. So for an unexercised animal, you see a reduction in synaptic coverage of both excitatory, represented by staining for V-GLUT1, which is a marker for excitatory neurons, and inhibitory neurons. So this was a GAD67 marker that we used to look at inhibitory neurons. And you get a 37% reduction in both of those compared to just intact animals. However, when you exercise an animal, you end up getting about, it's about up to the untreated animal level, which is amazing. So that means in some way, we know exercise is helping to reduce that reorganization and sustaining those motor neurons or the synaptic connections onto the motor neurons, which is great news because we need to be able to stabilize those synaptic connections to potentially make sure that after regeneration happened, that the neurons are still able to get those messages. So then we asked the question, well, is this happening in a sex-dependent manner for the type of exercise necessary? And yes, once again, we found that for percentages of the excitatory coverage, that males did much better for the continuous and females for the interval trained. And then for the inhibitory synaptic coverage, we also found that continuous training for the males and interval training for the females was the most effective. So this is going to be really important as we're starting to think about how to manage patients, because a lot of people, when they go into a physical therapist, they are treated for their injury. So the physical therapist says, oh, you're here for sciatic nerve injury, you're here for X injury, let me give you the treatment plan. But realistically, you need to start retraining physical therapists to start considering the sex of their patient as part of their treatment plan. So, oh, you have this injury and you are a female, or you have this injury and you are a male. How am I going to now work with coming up with exercises you're going to be more efficient? Because based on our research, what we've shown is that females, if they were given continuous exercise, have no better outcome than if they had been sitting around doing nothing. The males, if they were giving interval exercise, maybe they'd see some differences in their sensory neuron regeneration, but not for the motor neuron regeneration. And so we need to be able to tailor the appropriate physical therapy outcome to the appropriate exercise to the appropriate outcome that we desire. So that was one of the really big keys when we're talking about novel therapeutic development, is exercise is going to be a great therapeutic. However, real world problem in our research question kind of collide. Most patients with nerve injuries, traumatic nerve injuries, can't get up and exercise immediately after their injury. So that's a big problem. And previous research has shown that delaying exercise likely doesn't result in the same enhancement of regeneration. So what do we do? So part of the research question that I've been studying while I've been at the College of Charleston is, can we determine what mechanisms underlie the effects of exercise on axon regeneration, on sensory neuron participation, motor neuron participation, and synaptic reorganization? And can we take these mechanisms and create a patient treatment that could be used in lieu of exercise? So then we need to figure out, what is exercise doing? So that's the big question, is how do we put exercise into a pill? So the first thing I went back to was that very strange, very surprising sex difference that we saw in the different paradigms and how they worked for enhancing the regeneration. And remember, I showed you earlier that the males responded to continuous exercise, but not to interval exercise. Females responded to interval, but not to continuous, for the motor neuron participation and for synaptic reorganization, stabilization, and for the elongation. So we did some experiments where we looked at the serum testosterone levels in animals who have been continuously trained or interval trained, and found that for males that had been continuously trained, they had a very large increase in their serum testosterone levels. Females did not. And then for interval trained females, there is a slight increase. It is possible that this is biologically significant while it's not statistically significant, but this change in the male serum testosterone levels is really striking. So we started asking questions, what happens if we get rid of this serum testosterone? If we get rid of gonadally derived testosterone, will we change how the animals that respond to exercise? So the easiest way to get rid of gonadally derived testosterone is through castration. So we had our male animals that we continuous trained, our female animals we continuous trained, and then some castrates that we also trained. And again, we're looking at the median axon profile length, how long an axon has gone. And this is relative to untrained, which is going to be our 100% line right here. Anything above is longer than untrained, anything below is shorter than untrained. So in this case, we have our males with continuous training having much longer axons, females not responding, and animals that have been castrated don't respond to the continuous exercise anymore. So this strongly suggests that gonadal testosterone is an important part of the signaling complexes that are happening during that continuous training. So interestingly, castrating the animal does not turn it into a female. So we had also looked to see what happened with interval training, and it does not all of a sudden start responding to interval training. It acts just like the males did. So the females have this nice increase in axon elongation. With interval training, the males do not, and the castrates don't either. So that led us to ask the question, well, what's going on in those animals? And how can we know what's going on with, is estrogen or is testosterone part of this? And you can't easily castrate a female. You can't get rid of gonadal testosterone. So another alternative is to use an androgen receptor antagonist. And that's what we did in this next set of experiments. So again, this is the fold change in axon profile length, with the one line being the untreated, untrained animals. We have our increase from continuously trained males, increase in continuously trained females, and then animals who were treated with flutamide, which is an androgen receptor antagonist, and receiving exercise, all of a sudden abolished their effects of the exercise. So these were continuous trained males was treated with androgen receptor antagonists, all of a sudden no longer had the same effects of the exercise. Interval trained females also given the androgen receptor antagonist no longer had the effect of the exercise. So this was really striking. This was the first time that really suggested that, that these were going to be important. The androgen receptor signaling was important for this enhancement and part of the system of the regeneration. So then we said, well, is testosterone important for the synaptic reorganization? And some experiments were done by our English, Kaiwei Liu and Jill Ward, and they looked at the percent coverage changes for those excitatory synaptic connections onto intermotor neurons, as well as the GABAergic or inhibitory synaptic connections onto motor neurons. And when they had a transection, of course, they saw that decrease in synaptic coverage we saw before. When they exercised it before, they saw that it came back up to that normal, as I showed you earlier. And then when you treat with flutamide or you block the androgen receptors, then all of a sudden you have this loss of the effectiveness of the exercise. So exercise becomes basically ineffective whenever androgen receptors are blocked. So this was a really big sign that androgen receptor signaling and testosterone are important, important for the exercise effects. So this was potentially a novel therapeutic that could be used. Somebody could potentially use testosterone to potentially treat these patients. However, I was really curious about what was going on in these females, and that wasn't quite easily explained through those results. And those increases in serum testosterone that we saw earlier may actually lead to an increase in estradiol, because some components of testosterone can be aromatized and some type of testosterone can be aromatized and turned into estradiol. Now we know that gonadal testosterone is important for that enhancement of axon regeneration and may be important for synaptic reorganization. So I asked, could there be a role for estrogen? Could estradiol and estrogen signaling be an important process for what's going on with these animals? So in a set of experiments, Melinda Costa, Jamie Harrell, and Tricia Copley, they wanted to look at motor neuron participation and regeneration that we looked at before to see what the effects that estrogen signaling may have in getting motor neurons to participate in regeneration. So the effects that we saw early on exercise, which you can see here for males and here for females, is that going to be due to some type of estrogen receptor signaling? So again, this is a fold change in the labeled motor neurons compared to our dotted line, which is the untreated, unexercised. Treadmill treated, you can see that we have an increase for the males and an increase for the females in the number of motor neurons participating. When we then took these animals and we treated them with an estrogen receptor antagonist, we see that the exercise is no longer effective for the males or for the females. When we treat them with estradiol and have no exercise, we get an enhancement that is very similar to what we saw with exercise. So this suggests not only that exercise might be, the exercise effect might be mediated through estrogen signaling, but estradiol or estrogen signaling may be sufficient for producing an effect very similar to what we saw in the treadmill training. And importantly for the females, what we saw is when we treated with this ICI, which is an estrogen receptor antagonist, that we saw a decrease in the number of motor neurons participating well below what an animal would have if they were just sitting around receiving no treatment at all, suggesting that estradiol and estrogen signaling is incredibly important just for these motor neurons to participate at all in some type of regeneration process. So estrogens are also, we asked the question whether or not estrogens could be having the same effect for sensory neuron participation, because this was really exciting. We already talked about how the motor neuron participation and sensory neuron participation are both really important. We just saw this massive effect from the estradiol's effect on motor neurons. So we wanted to know, does it have an effect on sensory neurons? So this work was done by Brenna Casey, Kira Von Fort, Catherine Epley, Josh Goodman, and Amanda Dawson. And they looked at the number of labeled sensory neurons for both females and males. And in untreated, these animals had, for females, about 200 labeled DRG or sensory neurons. And when you treated them systemically with estradiol, you saw this increase to about 500 sensory neurons. That's a huge increase. And then when you treated them locally with estradiol, you saw this similar increase. And the same thing we saw for males. When treated with the estrogen receptor antagonist in exercise, you saw a reduction in the number of motor neurons or the sensory neurons participating. And this is really important. And you may wonder, why do we treat the animals both systemically with estradiol and locally with estradiol? And you may know, if you've taken hormones and behavior or thought about it, that a lot of work has been shown in the past that giving humans estradiol in large doses systemically can actually increase the risk for stroke. So this is something that, as we've been thinking about estradiol being a potential novel therapeutic, is not something we don't want to cause people to have stroke whenever we're trying to treat a peripheral nerve injury. So one of the questions is, can we have local treatment of this estradiol and still have the same effects? And yes, we can. And this is great because we've created a formula that we've been able to lock that estradiol into this fibrin matrix and be able to give it at the time of the nerve injury, during the surgery to repair the nerve, and it seems to have this effect very locally without having systemic increases in estrogen. So this is really important so that we can potentially think about this as a novel therapeutic. So we've now shown motor neuron participation, we've shown an increase in sensory neuron participation with estradiol. So then we had to ask the question, what happens to that synaptic reorganization? And this is work that Vernon Kennedy and Shanice Wilson have been working on in the lab. And they've been looking to see what happens to that percent coverage. So we talked about how those motor neurons, they lose their synaptic coverage during injury. And you can see this right here. So this is looking at the excitatory synaptic coverage for males and for females. And the zero line is intact animal. So for transection, you can see that injury reduces again about 35% for both males and females. And when you treat that animal with estradiol, you have basically no effect of, you don't have that synaptic withdrawal 2 weeks later after the estradiol treatment. This is very similar to what we saw with exercise, and very similar to what we saw with the testosterone treatments. So this is really exciting because this is now showing that estrogen receptor signaling can increase motor neuron participation, it can increase sensory neuron participation, and it can help to sustain synaptic connections on the intermotor neurons, making it a really good idea, or a really strong possibility for some type of therapeutic treatment for somebody who has sustained peripheral nerve injury. So we're starting to build a model of how this might work. So we know that exercise is important for regeneration, for synaptic stability, and elongation. And we wanted to know, okay, what are some of the mechanisms? And we've identified estrogen and testosterone. However, this is a little bit curious because if you think about it, in these cases where we've been talking about this, we've had a situation where when we blocked androgen receptors and we've seen a loss of the effect of exercise, estrogen receptor signaling is probably still intact. And when we blocked estrogen receptor signaling, testosterone signaling androgen receptor signaling was still intact. So this is kind of an interesting finding because neither of them by themselves seem to, if you take out one, you lose the effect, but the other one's still intact. So we wondered, is there something else going on? Is there another molecule upstream of this that is really important that we haven't captured yet? And what could that be? So based on some research that I did when I was in my postdoc, I thought maybe one of the ideas could be brain-derived neurotrophic factor. So brain-derived neurotrophic factor have been described by other people as one of the growth factors that's upregulated after a peripheral nerve injury. So shortly after the peripheral nerve injury, the mRNA levels and protein levels of brain-derived neurotrophic factor increased quite dramatically. So one of the questions I had is this going to be, if we treat animals with BDNF or we give BDNF at the site of injury, can we end up increasing the elongation of axons? Will we effectively help that regeneration? So again, we're back to our WAFP animals. So we have those yellow fluorescent axons. Anything above this white line is that proximal portion that's still attached to the cell body of the motor neuron. And anything to the bottom is that part of that distal part, which is going to be new axons that have grown after the injury. And again, that white line is going to be the cut. So our untreated animals, again, we see growing about 1,000 microns. Our animals treated with exercise are growing, in this case, quite a bit longer. So they made it to about 4,000 microns in these experiments. Animals just treated locally with brain-derived neurotrophic factor also have massive growth elongation. So they also make it to about 4,000 microns, which is very similar to what's happening in exercise. So our question was BDNF one of the molecules important for exercise? So we created some animals that were BDNF knockouts. So they lacked BDNF, and we also gave them exercise. And what we discovered is that whenever you took out BDNF, you lost the effectiveness of the exercise. So that exercise is dependent upon BDNF. So this was another idea. This could be another novel therapeutic. Unfortunately, BDNF is really large and it doesn't cross the blood-brain barrier very easily. So some colleagues started thinking about, is it possible to come up with a BDNF mimetic? So something that looks like BDNF, is very similar to BDNF, but isn't BDNF. It's much smaller, so it's able to cross the blood-brain barrier. So I participated in some of these experiments, and these were published by Art English's group a few years ago. And what they did is they looked at 7,8-DHF as a mimetic, as well as deoxygenin, and they discovered that, and again, these are yellow fluorescent proteins that actually look a little bit more yellow, but the same experiments we've done before. So this is the part of the nerve that is connected to the cell body. This white line is that surgical cut, and anything below that is going to be the axons that are elongated. And in this case, they're untreated, it's about 1,000 microns as always. Animals treated with that mimetic, the 7,8-DHF. They grew to about 2,000, 2,200 microns, and animals treated with the deoxygenin grew to about 2,200 microns as well. So they saw this really nice increase in elongation, this enhancement of elongation of axon by treatment with BDNF mimetics. So again, this could be another novel therapeutic. I don't have any data yet to show if these BDNF mimetics play a role in participation of motor neurons or in sensory neurons after injury. However, we have looked to see what role BDNF might have in the sustenance of synaptic connections after the peripheral nerve damage. So this was a paper that I worked on with Joey Krakowiak, Kawe Liu, Chandana Papadesu, Jill Ward, and Art English a few years ago. And again, we were looking at synaptic coverage on the y-axis, and then we had our intact animals, so animals with no injury, animals with injury, animals with injury who were also exercised. And in this case, I'm going to bring your attention over here to these white bars. So for an animal, these animals lacked BDNF, so they had no BDNF. But the animals in black and in gray had BDNF. So if we had a situation in which we took BDNF out, then we can see that the lack of BDNF during exercise reduced the synaptic coverage. So exercise typically would increase synaptic coverage after transection. So transection is here. You see lower synaptic coverage than you do here. So this black bar here is lower than this black bar here, meaning that exercise is increasing synaptic coverage for these excitatory neurons. But when you remove BDNF, it looks very similar to the transection animal and the one that got exercise. There's really no difference. And this is true for both excitatory and for inhibitory synaptic connections. So BDNF is going to be really important for sustaining the synaptic connections. So again, here's another target potential novel therapeutic that could be used if we can find another mimetic that could be used to cross the blood-brain barrier. It may also be part of this gap right here. So it could be that exercise is altering BDNF, and that BDNF is somehow related to testosterone and estrogen. And in fact, we know that there's estrogen binding domain on the primer for BDNF, so that estrogen can actually increase the amount of BDNF, and that animals that have been overectomized, so when you remove the ovaries, you have a massive reduction in estrogen, and that also reduces BDNF. BDNF in these animals go down to about 0. When you start treating animals with estrogen again, then the BDNF levels begin to come back up. So we know that there's an interaction between estrogen and BDNF, and there's also some links between BDNF and testosterone. And then we talked about before that testosterone can get aromatized to estrogen. So we may now have this little triad that somehow is involved with exercise. But how is exercise doing this? As we talked about earlier, when you cut the nerve, you're cutting the connection between the muscle and the motor neuron. So realistically, the muscles that are being exercised are probably not sending signals back up into these cells. So what is going on? What is this happening in this region right here? So we did some experiments using optogenetics, in which we created a mouse that expressed channel rhodopsin. And channel rhodopsin is a channel that exists in the cell membrane, and when light hits it, it's activated, it opens up a pore and lets sodium through. Sodium entering into a cell is excitatory in most cases in the nervous system, so it causes that cell to have activity. So you can basically shine light in specific patterns and activate neurons. So for this animal, we created a cuff and lined it with little LEDs, and then sutured the cuff around the sciatic nerve like this, and then close the animal up, and we were able to turn the light on in specific patterns that tried to mimic treadmill exercise. So we went in, we cut the nerve, we repaired it with fibrin glue, and then we activated it using this implanted optical cuff, and we tried to do that similarly to what we would do for exercise. 3 days later, we harvested the tissue and then counted the number of motor neurons that were filled with our retrograde dye. And what we found is that the number of retrogradely labeled motor neurons were higher in animals that had been optically activated than untreated. So in untreated animals, there were about 100, 110 retrogradely labeled motor neurons. In the optically trained animals, there were about 225. So a very large increase. And we did a separate experiment in which animals were given 4 weeks after their original injury, and then injections were given into the gastrocnemius muscle. And these dye injections in the gastrocnemius would only label neurons whose axons had made it all the way back to the target musculature into the gastrocnemius. And you can see in this case that we only had about 50 to 60 cells whose axons made it back to gastrocnemius that got labeled for the untreated animals. But for the optically treated, it went up to about 175. So that's a really big difference. So that neuronal activity, just stimulating these neurons to work, increased the number of neurons participating in this regeneration. So it gave us another little piece of the puzzle. So exercise may be increasing neural activity. That may be then increasing BDNF and estrogen testosterone, or maybe estrogen testosterone working at BDNF, or maybe it's in a circle. We still have a lot of question marks, a lot of questions to see how we're going to work it out. But here's kind of the current theory. So we think treadmill exercise, continuous for male, interval for female, probably increases serum levels of tissue or tissue levels of androgens, and also neuronal activity. Increases in neural activity probably increase BDNF, which increases protein translation, which can lead to our enhanced outcomes. We can also have serum testosterone levels, serum the androgens. They can bind to their androgen receptor, which then can potentially increase neuronal BDNF or Schwann cell BDNF in some way, which can lead to protein translation that can give us that restored synaptic input, reduced synaptic withdrawal, and an enhancement in axon regeneration, as well as motor neuron and sensory neuron participation. We can also have this increase in androgens, can be aromatized, some of it can be to increase in estrogen, to activate estrogen receptors, which then might go down and work on BDNF to go that pathway as well. Interestingly enough, there's also this other pathway up here that I didn't really talk about, but we found in our lab. I had several students a few years ago, Angel Tarot, Brenna Casey, worked on a project with Tricia Copley and Merlina Costa and Andrew Nelson, in which they looked to see what happens with animals who were given voluntary access to exercise. So they were put into cages that had an exercise wheel. The wheel had a counter on it, so they were able to count the number of rotations that the wheel gave. The animals have free access to this. And generally females would run a lot. Males and females would run quite a bit, but the females always ran a lot longer, meters and meters and meters a night. When treated with an estrogen receptor antagonist, that number plummeted. The amount of exercise sometimes went down to almost 0 meters per night. And this was not because the wheel was broken. They just weren't motivated to exercise anymore. So it could be that what we're seeing in some cases is actually an interaction in which we're getting exercise to change estrogen, and that estrogen receptor activation could then go back and change our motivation to engage in exercise. So we can get this backwards relay here as well. So this is kind of the schematic we're working on right now. There's still lots of open questions, like, what factors are altered by exercise to produce the changes in BDNF, testosterone, estrogen? Could it be intermittent hypoxia, them running and then getting out of breath? Could it be metabolic changes? Could it be something else? As we're identifying these new therapeutics, these new mechanisms like estrogen, testosterone, BDNF, and neuronal activity, when do these need to be administered? So we already know that exercise can't be administered too late. We have too much of a delay, but realistically, most people can't get up and start exercising very quickly. So when do we need to start treating with estrogen? When do we need to start treating with testosterone? Is it best to do it together, do it separately, to do it where, what location? There are lots of questions that we still need to answer. A lot of research still needs to be done. So, hopefully in the future, people will be able, after they have their injury, hopefully they don't have injuries, but if they do, after they see the surgeon can try to recommend either a physical therapist or a pharmacist or both to try to help with some of these treatment options. So I want to thank my current lab team. This is Shanice Wilson, who is a senior at the college, Rochelle Peterson, who's a senior at the college, of course me, Vernon Kennedy, who is a senior at the college. They have been doing quite a bit of the work that I talked about. Grace Bader is a sophomore who is getting started on a lot of these projects. Kaylin Vineling graduated last year, and Kenny Moreland, who is joined the lab and is going to be starting to work, coming on some projects pretty soon. Of course, my collaborators are Art English and Jill Ward at Emory University, and then my funding from NIH, HHMI, the psychology department, the Dean's Office in Humanities and Social Sciences, as well as undergraduate research and creative activities office. So thank you so much. And if you have any questions, feel free to reach out to me. My email address is wilhelmjc@cfc.edu. I'd be happy to take